Are live now, sir. Over to you.
Yeah. Good evening, all the participating doctors. I, Partho Chakraborty, welcome you all for today's ECME on chronic cough. We are really fortunate today. We have Dr. Talwar with us as a speaker. Welcome you, sir. Sir, Lupin in its 53 years of establishment has the vision to be an innovation-led transnational pharmaceutical company with a clear focus on quality and compliance. It stands out to be sixth largest pharma company in India with presence in more than 25 therapeutic categories. And respiratory is one of our mainstay as a team. Now coming back to today's topic of chronic cough, fine-tuning management in 2021. And we are really fortunate to have Dr. Talwar sir with us. Talwar sir needs no introduction. Dr. Talwar is the director and chair pulmonology, sleep and critical care medicine in Metro Institutes and Health Sciences, Noida. Talwar sir is a fellow of American College of Chest Physicians and National College of Chest Physicians in India, fellow of Indian Sleep Disorders Association, and fellow of Indian College of Allergy and Immunology. Dr. Talwar is teaching in church DNB respiratory medicine since 2008 and fellowship program in interventional pulmonology under IAB and ICS. Dr. Talwar is having 169 research paper publication in Indest and PubMed journal, which includes NEJM and clinical infectious disease, BMJ, chest and respirology, asthma and allergy, and clinical immunology, and American Journal of Respiratory and Clinical Care Medicine, along with European Respiratory Journal. And the introduction can be very heavy. With this short introduction, I now request Dr. Talwar to take over the session. Over to you, sir. Thank you.
Thank you, Partha. Thank you, Lupin, for having me on this platform today to discuss about a very important issue, which is, of course, of tremendous importance to all of us as we see it almost every day in our daily practice. And it is going to talk about chronic cough. And my job today is to tell you how to fine-tune your management in 2021. I think the context of this is very clear, that why we talk about chronic cough. And the reason is that it is the most common symptom which we see in the general as well as the chest consultations. So patients come to the OPDs primarily with very common symptom of cough, which just refuses to go. Now, this kind of chronic cough is primarily playing a lot of emotional issues in the mind of the patient when they continue to suffer from this condition and are not able to get the adequate relief. Embarrassment is one of them, which is felt by nearly 50% of people. Frequent retching is something which is seen in about, again, 56% of people. But more importantly is that patients are really concerned that if this cough doesn't go away, then perhaps it is looking like that I may be having something seriously wrong with me. And that is in the mind of 2/3 of people who report to the OPDs with this particular symptom. Because this symptom is something which is like smoke or love, which you just can't hide. So it is seen by public, it is seen by family members, and they are also equally troubled, and they accompany the patient to the doctor looking for an answer in the form of relief of this chronic cough. So to make the things very clear, I brought this picture which shows that why do we cough? Is it something which is so sinistrous that when it is persistent and chronic, it should have placed so much of importance on the mind of the people that they start wondering that it may be cancer? So just to recapitulate, that cough is also one of the reflexes, as we have other reflexes. You know, we have corneal reflex, you know, we have ankle reflex. Cough is also a reflex like that. So being a reflex, its function is what? Protection. All reflexes are supposed to protect. So this is also a protective reflex. And as with all other reflexes, it has a receptor which is present in the respiratory system, either in the epithelium or in the nerve endings, as it is being shown here. And from these receptors, which are nociceptive receptors, which are the receptors of cough, which can be naked nerve endings, or it could be in the epithelium in the form of cytokines, or again, certain certain kind of a stimulation in the epithelium, which is produced by the pressure or the inflammation, leads to carriage of this kind of signals from these receptors via the nerves, which are the afferent nerves. And the afferent nerve from the lung is vagus. And this takes this sensation to what is called as a cough center. And this cough center is situated in the medulla. And from there, it sends the afferents after processing through the motor output, which is in this form of spinal neurons, as well as other nerves like vagus, as well as the trigeminal nerve, which is the fifth cranial nerve. And these signals, which are the efferent signals coming from the cough center, finally reach the effectors. And the effectors for the cough is the respiratory muscles, including diaphragm. So once this is stimulated by the stimulation of the receptors, it ends by the contraction of the respiratory muscles, which contract in a way to throw whatever has caused the irritation out of the body. That is the protection it is supposed to provide you. So then the question comes, why do we want to suppress a protective reflex? Primarily because it is when it becomes chronic and it becomes hypersensitive, then it becomes more troublesome rather than doing some defense mechanism or protective mechanism. And very importantly, we need to clear the airways with this. But one important aspect of it is that cough is the only reflex in the body which you can have a voluntary stimulation also. I can cough just when I want to do it without any stimulation. So where has it come from? So it is from the higher brain, cerebral cortex. And this area also sends sensations to the cough center to initiate the cough reflex. So it is only reflex of the body which can be initiated voluntarily too. And this is very commonly used in a Greek proverb. When you are at loss to say what next, you start coughing to buy some time. Now, this is a reflex which has got three phases. And it is very important to understand that these three phases are constructed in a way that it is able to clear the airways. So it is followed by the first stage, which is the inspiratory phase. And you can see in the inspiratory phase, the pressure becomes negative and the flow becomes negative also. And it draws the air inside the lungs. And then comes the closure of the glottis. Once the glottis closure occurs, the second phase is started, which is called the compressive phase. Now, with the closed glottis, there is a compression produced by the respiratory muscle contraction. And since this is against the closed glottis, the pressure rises immediately with the peak levels coming up. And the flows are at that point of time not occurring at all because the glottis is closed. So sudden increase in this pressure, which is occurring because of the closed glottis, it leads to generation of pressure in the respiratory system to the tune of 300 millimeters of mercury. It is a huge pressure and can cause even a barotrauma. Once this pressure is built up, then the part of this is that the glottis will open. And that leads to development of the third phase of this reflex, which is called explosive phase. And in this, once the glottis opens, as you can see at the top, when the pressures are maximum, at that point of time, sudden opening of glottis causes fall in pressures with increased flow rates coming out from the airways. And they are in such a high speed that when these flows come out, they bring whatever is the secretions or the foreign material in the airway, which has initiated the cough reflex to the outside environment. And that's the process of cough. And this is the expiration phase where there is a lot of noise being produced, primarily because the air is going across the glottis where the vocal cords are vibrating and causing a lot of noise production, which is associated with the cough. So you can see these components of the cough, which have been based on the physiology to build up the pressures in the lung to such a level that once suddenly in an explosion, if it is opened, when the air will leave along with whatever is the foreign material or whatever is the abnormal material which is trying to stimulate the cough receptors. The cough is classified into acute, subacute, or chronic, and it is called acute when it is within 3 weeks of duration. So any cough which is of less than 3 weeks duration is called acute cough, and the most common cause is a viral infection. But also pneumonia and acute exacerbations of COPD and asthma can lead to development of sudden onset acute cough, which may last up to 3 weeks. Chronic cough is the one which is labeled after being present for more than 8 weeks. And anything between 3 to 8 weeks is called a subacute cough. And the importance of classification of cough is that this duration is basically the first step so that you can narrow the differential to the potential causes of the cough and then can proceed with the treatment. Chronic cough is so common that it is present in about 12% of the population, but it constitutes 80% of the consultations in the general practice. So cough under evaluation would require to determine what is the duration of that cough. Is it into the acute or the subacute or into the chronic category? So once we start evaluating a chronic cough, there are certain things which are useful and certain things which are not useful. Very frequently, we ask quality, like is it barking? Is it honking? Is it brassy? That does not give us any etiological clue. Same way, even timing, like we generally like to time the cough nocturnal or with meals to the one which is related to the GIT system. But it rarely helps to make the diagnosis of gastroesophageal reflux leading to development of cough. Very commonly, we ask productive versus dry cough. So unless and until it is like a copious amount of sputum production, it does not again give any etiological clue to the cause of chronic cough. So the important thing in evaluation is to know what are the red flags. Red flags are the ones that if the patient of chronic cough complains of these symptoms, you should immediately start looking for this etiological diagnosis, pursue it till you are able to sort out this symptom. And these symptoms called so-called as red flag symptoms are hoarseness of voice, hemoptysis, pedal edema, dysphagia, recurrent pneumonias, and a patient who develops dyspnea during the rest or night. But very importantly, any dry cough which is associated with systemic symptoms like fever, weight loss is something which needs to be investigated thoroughly. Similarly, a chronic cough in a patient who has been current or past heavy smoker also needs to be evaluated more closely to look for an ominous cause of this chronic cough. If you examine the patient and you find abnormal lung findings, that should also be documented and then evaluated further to find out why they are there and is there something more significant as well as treatable condition which can be picked up by detailed investigations. So remember the red flags in chronic cough, very important: dysphagia, dysphonia, hoarseness, hemoptysis, constitutional symptoms, etc. Now, what is a typical scenario of a patient who walks in with a chronic cough? More common in women in 5th to 6th decades of life, often frustrated and very frightened because they have tried many treatments at home, over the counter, and maybe at their GPs. And physical symptoms produced by this kind of a chronic cough may be disturbing to the patient. They may be retching and vomiting after a bout of cough. There may be urinary incontinence in these female patients. There can be a syncope, and which can be even dangerous because they may hurt their head or they may get injuries. There can be subconjunctival hemorrhage. There can be a fracture of rib, and very frequently, a chronic cough is accompanied by sleep disturbances. So to sum up, these patients look as if they are socially as well as psychologically broken when they approach us for the appropriate management. But before I finish, another kind of cough which has been troubling us for the last almost 1.5 to 2 years is a patient who comes with cough and sneezes and is at the scare of spreading a disease called COVID-19. So COVID-19 related cough is another type of cough which is coming into long COVID or post-COVID, which is chronic and troubling the patients. It's just simply like a post-viral cough with a different etiology. So how is this chronic cough approached in clinical practice today, and how we can change it? So if you look at it, there is a survey of patients who were having chronic cough, and 70% of them said that they don't feel happy because their physician has not been able to deal with their cough effectively. So more than 2/3 of patients feel that the physicians have not done their job good with them, and that's why they are not getting cured of their cough. 57% of these patients, so that more than half of the patients of chronic cough feel that whatever treatment has been offered to them is totally ineffective. And very importantly, even after 3 consultations with the physicians, 50% of the patients say they have no clue to their diagnosis as to why they have cough, even after seeing 3 doctors. So this is the kind of perception which we have at the moment for the chronic cough, where the treatment starts with Dadima's Nukse, which is basically cure your cough at home by various home remedies, as well as through the Google, where so many other things are being advised to these patients of chronic cough. We really, really need to change the practice in 2021. And that's what we are going to discuss, how to fine tune it. So remember, whenever a patient walks in with chronic cough, there are big 5s for that. Like whenever we go to a safari, we want to look at these big 5 animals which are being shown on the picture on the left. And these big 5s are bronchial asthma, laryngopharyngeal reflex, which is because of GERD, upper airway cough syndrome, which is because of chronic rhinosinusitis, ACE inhibitors and other drug-induced coughs, and a condition called non-asthmatic eosinophilic bronchitis. These 5 main causes of chronic cough constitute nearly 90% and above of patients who enter our clinics with chronic cough. But as I said, not to forget, COVID-19 post-infectious viral cough is now adding into this big 5, and maybe in the coming years, we will be seeing big 6. Because of the chronic cough, patient develops what is called as a cough hypersensitivity syndrome. This is a rather new entity, which is characterized by patients who are having chronic cough with minimal or no sputum. Generally, the cough gets triggered by cold air, speech, eating, or different odors or perfumes. And there is an urgent urge to cough from the throat, like there has been itch or a tickle, which comes through the throat and initiates the cough. And it leads to really a poor quality of life of the patient. And if we do a Kapacin test for the cough reflex challenge, it is positive. And this happens in conditions of what we have discussed as big 5: asthma, reflux esophagitis, rhinosinusitis, ACE inhibitors, and non-asthmatic eosinophilic diseases. And in these diseases, because the cough is chronic, then it becomes hypersensitivity syndrome, where it takes longer to recover because the larynx has become very, very sensitive to this cough. And every small little trigger which is trying to hurt the larynx, or even like scratch the larynx even by the air or whatever it is, it leads to development of the cough. And then it is a self-perpetuating thing where cough leads to more cough, and more cough leads to cough and more cough, and hence it becomes a vicious cycle. We need to break that. So how are we supposed to approach and evaluate chronic cough in 2021? So it includes 5 steps. Step 1 is a good clinical history and examination, and looking for the clues as to the cough etiology. And we move on quickly to imaging of the airways, upper airways as well as the lungs, and we use simple radiology and try to look for the cause. This is perhaps the most common investigation done for patients of chronic cough, but it is useful only in less than 7% of cases. So what it means is that although it is done, the primary reason to do it is to rule out underlying diseases which can be picked up by imaging. But this is very unlikely to be there. In step 3, what we do is profile this. Profile patient's characteristics, which we have gathered from the clinical history, physical examination, and the imaging studies with the etiology on the other hand. And when they match together, we make the diagnosis: asthma, rhinosinusitis, gastroesophageal reflux, disease, or other causes, and start in step 4 with the empiric therapy for that. You may ask me that why did I use the word empiric therapy? Because we have already narrowed down the differential diagnosis to an etiological cause, because these etiological causes are tentative. There is no definitive cause known for them at the moment. So we start with the empiric therapy. How long to give it? Generally, we give about 6 weeks to 12 weeks. And invariably, if the patients do not respond to that, we move on to step 5. And what is step 5? Step 5 is multidisciplinary team, which requires an ENT person, which requires a speech therapist, a good respiratory physician, and even sometimes a gastroenterologist to pitch in to get to the effective management of the etiological causes which may be there in an individual patient and not one cause. So what about asthma? So as I told you that most common cause of chronic cough is asthma, and it is generally asthma has symptoms like breathlessness and wheezing, but they can have a chronic cough also. And it should be considered as a potential etiology because asthma is a very common condition. 57% of asthmatics have cough. Cough is commonly associated with it, and usually it is nocturnal and indicates the worsening of asthma control. And all you need to confirm it is to do a reversibility, where you need to demonstrate improvement in vital capacity or FEV1 of more than 12% and more than 200 ml in absolute terms. However, the underlying lung functions may be normal, and a patient of asthma can present with only cough. And in those situations, we call it cough variant asthma. So reversibility will not be seen there, but atopy may be there, which might be giving a hint that this is a cough variant asthma. And for this, there is a grade A recommendation by ACCP guidelines that we should treat them with inhaled therapy of salbutamol as well as corticosteroids and add on montelukast if needed. Second important cause of chronic cough is the upper airway cough syndrome, which is in short also called as PNDS. PNDS or rhinosinusitis or UACS, what we call it, is seen in about 40% of patients of chronic cough, and it presents as recurrent throat clearing, sensation of drip at the back of the throat, and there is a heightened sensitivity at the cough center that it keeps initiating and makes it as a cough hypersensitivity or cough hypersensitive response. Most commonly, it is the cause of cough in adults, and very importantly, this kind of a cough due to rhinosinusitis may be silent in the terms of symptoms of rhinosinusitis. So like 20% of patients who have a cough due to upper airway cough syndrome related to rhinosinusitis may have no symptoms pointing toward the sinusitis. And even if you do imaging like MRI or CT scans, it may not pick up so well as it is being shown here. If you examine the throat, you can see cobblestone mucosa, you can see the drip coming down, but these are very rare instances. Most of the time, simply a red throat is an indication that it might be, but more important indications come from the type of symptom. Throat clearing and sensation of something sticking at the back of the throat or something dripping at the back of the throat. And in such situations also, it is the empirical therapy which is given to treat UACs and subsequent improvement as well as resolution of the symptoms, if it occurs, that only confirms the diagnosis of UACs. So I hope you understand why I said empiric therapy. The third most important cause of chronic cough is a gastroesophageal reflux, which has got a very close link with cough, because the reflux which comes into the upper part of the throat actually soils the laryngopharyngeal area and leads to development of laryngopharyngeal reflux. You can see how it looks red and beefy. The larynx, the false vocal cords, the true vocal cords, area surrounding it, all looks red and hyperemic. The important point to remember for gastroesophageal reflux related cough is that we think it is a nocturnal cough, but it is not. It is usually occurs when the patient is awake and not on lying down, usually occurs when the patient is upright. And again, it can be also silent without any overt symptoms related to gastroesophageal reflux in nearly 1/3 of patients. So there can be cough related to chronic sinusitis or GERD without these symptoms being present. Cough in GERD is also multifactorial. It is vagal reflex because the mucosa stimulates the vagus and it takes it to the cough center. Bronchial hyperreactivity because of microaspirations, and also release of cytokines which like IL-8, which stimulates the cough receptors to produce cough. Again, a definitive diagnosis of GERD, which we try to do by upper GI endoscopies, barium studies, esophageal pH monitoring, may not be accurate because they all can be normal. Non-acid reflux can similarly produce chronic cough without it being demonstrated either on barium swallow or upper GI endoscopy, or it may even not be picked up by esophageal pH monitoring. And the disappearance of this kind of a cough with anti-reflux treatment, aggressive anti-reflux treatment, is actually the definitive diagnosis of cough, which is chronic in nature and related to GERD. Then we come to this new entity, which is called non-asthmatic eosinophilic bronchitis as an important cause, which is roughly seen in about 20% of patients of chronic cough. What is this condition? This is a condition in which patients have chronic cough. They have a normal chest X-ray. Lung functions are normal. Even if you will try to use a methacholine challenge, it will be negative. So there is no airway hyperresponsiveness. So that completely rules out asthma. There is eosinophilia in the sputum or BAL, which is more than 2%, but it is hardly ever done. And the only surrogate marker of eosinophilic inflammation of the airways is exhaled breath nitric oxide. And if it is more than 20, it is indicative of the eosinophilic infiltration or inflammation of the airways. Allergen etiology like atopy is not seen, so it is not IgE mediated, it is eosinophilic mediated. And as you can see this picture, that the difference between asthma and non-asthmatic eosinophilic bronchitis is the different cytokines which are being produced, and they are primarily acting at the epithelium and the airway muscle, where the stimulation of the airway smooth muscle will finally lead to development of the cough. The difference is that the mast cells which are seen in the asthma in the airway smooth muscle does not occur in patients with the non-asthmatic eosinophilic bronchitis. These days, more work is being done and it is being recognized that this entity may be having small airway dysfunction only as a component which presents as a cough And it may be also seen in asthmatic or non-asthmatic people, because conventionally they may not fit into the diagnosis of asthma, but fulfill otherwise the criteria of asthma, in which there is only small airway dysfunction. We know asthma is a large airway disease, but now we also understand that in certain subset of people of asthma, it may be only small airway dysfunction. These patients, when follow up over 1 year, nearly about 9% develop asthma and 16% are overall going on to develop COPD. Coming to the fifth cause of chronic cough is the drug-induced cough. And the most common drug implicated is the ACE inhibitor, primarily because ACE is the one which breaks down bradykinin and substance P. And if you use ACE inhibitors, the accumulation of these substances, bradykinin and substance P, which are the stimulators for the receptors of the cough, leads to development of cough and increases the sensitivity of the respiratory tract. This kind of dry cough, which is due to ACE inhibitors, is seen frequently in females in 6th decade of life, and it is seen in 2 to 8% of them. It can occur after first dose, but usually occurs within the first month of starting ACE inhibitors, but sometimes can take many months. So I think the golden rule is any patient who comes with chronic cough on ACE inhibitors, your first job is to change the ACE inhibitors. Now, once you withdraw the ACE inhibitors, the drug effect will take to go for about 2 weeks, but the cough may not disappear so soon, and it may take up to 3 months. But very important to remember is not to shift one ACE inhibitor to another ACE inhibitor or even to ARBs. These patients are also prone to develop cough if we switch them to ARBs instead of ACE inhibitors. In these patients, there is increase in cough sensitivity, which is primarily precipitated by the bradykinins. There are other drugs which can also produce cough, like nitrofurantoin, phenytoin, sulfasalazine, and sitagliptin. And through other mechanisms, besides increasing the cough sensitivity, which happens by all these drugs which I just mentioned, there are other mechanisms which can also increase the cough or produce cough, like beta blockers. In an allergic people, asthmatic people, the beta blockers will unmask asthma. And here, even a use of ophthalmic ointments or drops of beta blockers can precipitate it in patients who are not yet diagnosed as asthmatics, and they start coughing. And then you do the test and you realize that they have asthma. And that will be the perhaps first time asthma will be diagnosed in them. Also, using calcium channel blockers in some patients leads to increase in gastroesophageal reflux, which precipitates chronic cough. So you need to look at all these drugs in the prescriptions of the patients, because they are generally comorbid with multiple other diseases like diabetes, hypertension, recurrent UTIs, and so many other things. And they might be using all these drugs which can be causing cough. And you have to tick mark and cancel one by one all these drugs from the list of the pharmacy which the patient is carrying with them every day. Now, coming to new cause of chronic cough in 2021, that is post-COVID. And of course, we cannot do any seminar these days without talking about COVID. COVID-19 can produce either an acute cough, which is with the acute COVID, or it can, after the acute phase is over, can persist, and it is called persistent cough. Now, post-COVID chronic cough is reported in as many as 18% to 40% of people. And as the time passes and patient shifts from post-acute COVID to long COVID, the cough decreases over a period of time. Which are the predisposing factors for the patients to develop post-COVID cough? Female patients again, patients who had severe COVID, and patients who have respiratory comorbidities. But very important differentiating feature between any post-viral cough, adenovirus, rhinovirus, other coronaviruses versus COVID-19 post-COVID cough is that post-COVID cough doesn't come as a simple post-viral cough alone. It comes with a multitude of symptoms. So there will be symptoms of fatigue, there may be symptoms of chest pain, chest tightness, nausea, vomiting, lethargy, sleep disturbances, host of long COVID symptoms along with cough is a post-viral cough. And this will become very important in the times now, because patients who have recovered from COVID and getting influenza infections now will have post-influenza cough, and it will be confused with post-influenza chronic cough versus the post-COVID chronic cough, or maybe both of them together. So we need to remember that the post-COVID cough is not a standalone feature. It comes with many bulk of symptoms along with it. And it can be because of parenchymal involvement, airway involvement, and it could be acute like an inflammatory phase, or it can be in the post-inflammatory phase due to fibrosis. How do we manage this cough? All chronic coughs are basically managed the same way. But the most important thing to see here is that the cough sensitivity in post-COVID patients can be reduced by using tiotropium. Pulmonary rehabilitation and speech therapy may work in these patients. However, we need to avoid opioids because of the dependence and side effects which are very likely to develop in this group of patients. What happens if the cough persists despite this empirical treatment of 5 to 6 causes which we have already done? So if we have done our homework well for this big 5 plus another 6 and given a treatment on the basis of clues to the etiology which we had, and the patient doesn't respond, what do? We divide them into again 3 varieties. Chronic refractory cough, when the etiological treatment has been given and it is not successful. Chronic unexplained cough, where we have no clue to the etiology for the cough at all, and we need to go ahead with the further investigations. And finally, when no cause can be identified by even the specialist in the special centers looking after cough, then it is labeled as chronic idiopathic cough. And these kind of coughs are very irritating, and you need to offer the treatment. What kind of treatments do we have? We have drugs to calm them down, and we have narcotics like hydroxycodeine and codeine. We have neuromodulators like amitriptyline and gabapentin, and we have also speech therapy to offer the patients of chronic cough. How do they act and how do they work? So one important aspect to remember is that when the initial treatment of cough fails, it is very disheartening to the patient, and you need to bring in a multidisciplinary team. And as I told you, pulmonary, rhinology, and gastroenterology are the 3 most important aspects of this the chronic cough. You may have other things to look for as it is being shown in this picture. But I think one important message which I want you to remember is that when these coughs do not respond to empirical initial treatments, it is not because of one condition, there are multiple causes. And in fact, 3 causes or more are seen in nearly 40% of chronic cough patients who do not respond to initial therapy, which we have done after our workup of step 1, 2, 3, 4. And here we really need to get the multidisciplinary team. As I told you, the 3 group of medications which we have are the narcotics, which directly act on the cough center, which is in the brainstem, and suppress them from coughing. But this needs to be so strong that patient needs to go to sleep. It cannot be differentially acting on the brainstem, the cough center. It will be definitely also affecting the overall cortical function and leading to development of sleep in the patient. So very significant side effect. Besides being the dependence, these drugs cannot be used to treat any kind of a chronic cough on a long-term basis. The other is that we know that the vagus nerve is both afferent as well as efferent for the cough receptors. So can we modulate the tone in the vagus nerve to decrease the cough? And there is where the role of neuromodulators. And these kind of receptors, which are not only present in the lung, they are also present in the larynx, trachea, bronchi, ear canals, eardrums, pleura, pericardium, diaphragm, esophagus, and stomach, and so on and so forth. So the cough receptors are present in so many other extrapulmonary sites that you always need to remember that even in otitis media, the patient may come up with only chronic cough. So these kind of things need to be remembered, but to blunt the responses coming from these receptors, you use neuromodulators. As I told you, gabapentin and amitriptyline are two of them. What about the efferents which are coming up from the brain, particularly the cough center? So can we change their signaling to the respiratory muscles? And that is what we do by speech therapy, where we modulate at the level of larynx as well as at the level of diaphragm and the expiratory muscles. So these are the three major therapies for the patients of chronic cough, which refuses to go away despite the treatment which we have made according to the big 5 etiologies which we have worked up for an individual patient. If you look at the guidelines, what kind of treatments are recommended for chronic cough from the chest and ERS? So you will see that speech pathology is very commonly considered, because this is because of the laryngeal hypersensitivity, where it keeps stimulating cough again and again. So you need to modulate it, and speech therapists do a wonderful job on that. Inhaled corticosteroids are used for not only asthma, chronic rhinosinusitis, but also for non-asthmatic eosinophilic bronchitis. Gabapentin is again recommended to modulate the nerve stimuli, and basically the nerves which are taking and bringing the stimulus from the cough center. Proton pump inhibitors most of the times are used for only GERD-related cough, and morphine is in the chest guidelines clearly put a plus minus, because this is not the drug of choice for management of chronic cough. So what are the other drugs available for us to suppress that? We have dextromethorphan and some other drugs which are non-opioid based. Dextromethorphan has undergone 3 RCTs, out of which 1 was inconclusive, and 2 of them showed that it decreases the cough counts as well as the sensitivity significantly. We have inhaled lidocaine, but it is extremely short lasting and it needs to be very frequently given, and hence again not a method of choice for management of chronic cough. Benzoates, which are derived from procaine, are the ones which are also being considered, and sublingual are the ones which have been used in the past. And they also decrease the sensitivity of afferents into the cough reflex hypersensitivity syndrome. And there are new kid in the block, which is going to be basically the peripheral airways sensory terminal blocker, where it acts on the sodium channel, sodium 1,7 channel blockers, which act on the sensory terminals of the airways, from where the cough receptors are getting stimulated and passing the stimulus to the nerves to carry it to the cough center. And these are already in the making and going under stage 2, stage 3 trials. Another drug which is available is a levocloprastin, which is a non-opioid antitussive. It acts peripherally by inhibiting the release of inflammatory mediators and reduces the bronchospasm. It is a levoisomer, and hence it is a safe and has got a good tolerability profile. On the same side or the same hand, it also improves the respiratory symptoms across all kinds of cough, acute, subacute, or chronic cough. And it is a levoisomer which is better, in fact, than dextromethorphan, and almost in clinical studies have shown to be as good as codeine, without, of course, the side effects of codeine. And this is one of the study which included 100 patients and did show a significantly reduced symptom burden, as well as the cough count and the sleep disruptions caused by cough. So at the moment in 2021, the therapeutic algorithm which is to be taken up for the patients to treat chronic cough starts with their history, pointing towards the big 5 causes. If they are on inhibitors or any drugs which can cause, you need to stop them, or otherwise you need to start working them on the investigational algorithm, which is like looking at the x-rays of the upper and the lower airways and lung function tests. If any cause is there, on the basis of these tests, obviously you'll treat the cause. But if there is no indication of any cause, in those situations, you give therapeutic trials. You give therapeutic trial of bronchial asthma, you give therapeutic trial of rhinosinusitis and GERD. So these are the 3 conditions in which you give an empiric treatment to see whether the cough becomes better or not. And very important, as I said earlier, because in 94% of times, the diagnosis will be one of these three. But in 40% of them, all three will be there. So in those situations, when we try to target one, invariably it leads to partial relief of cough, not complete clearance. So once we start the treatment, the only next question which comes is that if we start with the first line therapies, do we have alternatives? So you can see this chart from which is the guidelines from the chest, that in bronchial asthma, prednisolone, in rhinitis or UAX, prednisolone, but these are second line treatment when you have sufficient evidence to suggest the primary cause. In GERD, alginates, and in you can upgrade the therapies, but once the patient doesn't improve, you need to get the MDT into the picture for the patient's betterment and to get more effective management of chronic refractory cough. With that, I would like to thank you all, including Lipin, for having me here, and I'm open to any questions which are there.
Thank you very much, sir, for such an insightful and lucid presentation. I'm sure the attending doctors must have benefited from all the insights you have shared with us. So with your permission, can we move towards Q&A session?
Yeah, absolutely.
Thank you. So the first question we have from Dr. Sanjay Sood. How can we clinically judge from where the cough is originating?
So unless and until we have a direct clues that, the cough has origin from the esophagus, or is it from the trachea, or is it from the lungs, or is it from the upper airways, by means of having associated symptoms of that particular organ involvement, it is very difficult. So that is why it is called a chronic cough, which is idiopathic or unknown cause, because you are not able to find out which organ it is involving. So a lot of history and physical examination needs to be done for these patients. And of course, you have to do targeted testing. So if your patient tells me, I have a history of allergy, my family has history of allergy, my mother, my parents have, and then I had in my childhood recurrent sneezing and sore throats, and now I've come with a chronic cough. So I know this cough is related to allergy, and allergy atopy component could be either asthma or it could be a rhinosinusitis. Similarly, if a patient comes and says that, he gets frequent abdominal symptoms with gaseous bloating, retching along with cough, I know that there is association of this kind of cough with the gastroesophageal reflux. And the very important point to remember there is that these are like self-perpetuating. More cough, more retching, more vomiting, more reflux, and finally more cough. So it's a vicious circle and you need to break that. Drugs are very important. I think the first thing you need to do for every patient of a chronic cough is see what drugs they are taking. And you will be surprised. We know only of ACE inhibitors, but there are so many other drugs which can cause chronic cough, and they need to be considered. And first, they need to be omitted from the prescriptions, and then only you will start with the further management.
Right. So on the same line, sir, we have a question from Dr. Ajay. He's asking how ARB will cause cough.
Pardon? ARBs. Yeah. So, yeah, it's a very good question, because there are 2-3 studies which try to show that the ARBs do not cause chronic cough. So you can shift your patients from ACE inhibitors to ARBs. But then subsequently, it was seen that the cough sensitivity, that is the cough hypersensitivity, which I spoke to you about, once stimulated, then it can be easily stimulated even by the ARBs, which is related to their, again, a smooth muscle relaxation component rather than because of the bradykinins and what we are talking about in ACE inhibitors. So that is why there is a word of caution that if you are changing the medicine from ACE inhibitors, don't change it to ARBs at the moment. And even preferably not even calcium channel blockers, and remember, not beta blockers also. So you need to be very wisely choosing the drugs there to look for the alternatives where they are less likely to cause or least likely to cause cough when such a thing is there. So that's very important actually. So sometimes we use selective calcium channel blockers. Sometimes we use other drugs to treat it for the time being, let the cough settle down, and then we will introduce the drug and see whether it really recurs or not. because then it will be very easy to pick up. Because many a times some of the drugs are very essential from a cardiological perspective where we need to give it actually.
Thank you, sir. Next question is from Dr. Gupta again. What is the role of premature ventricular complex as a cause of chronic cough?
So I'm sorry about this question because I have no idea about the answer to this, that how PVCs can cough, but I do know that cough stimulates a lot of cardiac arrhythmias, and it causes a lot of cardiac arrhythmias. And in fact, these patients who frequently develop syncope, they undergo Holter monitoring also. And many a times we pick up very innocuous kind of cardiac arrhythmias there, which are not cause of that syncope. And the cause of syncope is actually the cough. And if you treat the cough, that the patients become better. And they are very frightened patients because they have fallen down and the family is completely shaken that if it happens somewhere else and they fall down suddenly, so it may cause a very serious mishap for these patients. They undergo very frequently even the Doppler studies for the carotids, whether the supply to the brain is correct or not, MRI brains, EEGs, extensive investigations are done for the patients of chronic cough with syncope. So syncope has been thought to that it could be because of the cardiac arrhythmias, and that's why the Holter monitors are done. And Holter monitors do pick up atrial arrhythmias quite often actually, but they are not the causative, they don't have a causal relationship with the syncope which these patients have.
Right. So next question is how to interpret multi-channel intraluminal impedance findings for diagnosis of LPRD.
This is absolutely a question from a gastroenterologist perspective. Impedance studies, we do not do it actually, but we should do it. But obviously the interpretation is also very difficult in this situation. So I think I'll pass this question to the gastroenterologist. I do not know how to do this because we are not doing it. We do esophageal pH monitoring, but then that has got a serious drawback because non-acid reflux can cause cough, chronic cough, as much as the acidic reflux cough can cause. So the important point to remember is to do just one study and finding out normal doesn't mean that the gastroesophageal reflux doesn't occur. And I think the clear-cut message is that you treat it and you see that if there is a response coming up, that will confirm the diagnosis. Not necessarily barium swallows or we need to do endoscopies there.
All right, sir. Thank you. Next question is pertaining to the epidemiology. So this doctor is asking epidemiological prevalence of cough based on ethnicity. For example, Chinese report chronic cough more often. So do you have any comments upon this?
Yes, that's true, that there is an ethnic difference, and this difference is also very significant when the patient actually approaches the physician with chronic cough. And that depends upon the sensitization of the community as well as ethnicity. So even in US, if you look at the white people complain of more cough than the Africans and the black people or Hispanics. So there is a difference in perception of cough. As I told you, why do the patients with cough come to us? So one of them reason will be embarrassment. So if somebody doesn't feel embarrassed, will not come to us. Somebody who feels even a slightest of cough is an embarrassing situation, will immediately run to the doctor. That is why the Western population, white population is definitely more complaining. And in fact, in their surveys, the incidence of chronic cough is almost to the tune of 24%, which is much higher than what has been reported from the rest of the world.
Right. Great, doctor. So next question, any comments on otic cuff reflex? I think Arnold reflex is asking about. Ear cuff reflex, any comments upon?
Oh, okay. So see, as I said, that eardrum as well as the middle ear, both of them has got cuff receptors, and they are the ones which are nociceptive, and they are in the eardrum, they are primarily related to the pressure. So even the pressure on the eardrum can produce the cough. Inflammation of the middle ear can produce the cough, and it is the receptors there, and the afferents are taken up by the nerves in the seventh and the eighth and the ninth nerves, and it goes directly into the brainstem. Brainstem is the cough center where there is an input of lot of extracranial nerves, and in fact, if you look at 5, 6, 7, 8, 9, 10, 11, 12, all of them are coming to it. So this is a big cough center area where there is an inhibitory area as well as an excitatory area, and there is an influence coming from the top, from the cortex.
Right. So next question is from Dr. Gupta again. He's asking, can mucosa thickening of nasopharynx would be an indicator of UX?
Okay, so UX word we particularly use when there is a sinusitis associated with it. So if there is only a mucosal thickening, or there is a the turbinates are hypertrophied and there is a blockage of the nose, it can produce cough primarily because of the postnasal drip, which happens of the normal nasal secretions, not from the sinus secretions. Sinus secretions are generally infected, and in fact, when they travel into the throat, they are very, very viscous. And since they are yellowish and purulent, this is the only indication to use antibiotics to suppress the cough. This kind of chronic cough needs antibiotics only because of the sinusitis element. But if your question is that can the nasal pathology itself without any sinus pathology lead to development of cough? Very commonly seen, yes. Allergic rhinitis, chronic rhinitis, both of them can do it.
Right. Next question we have is, what is the role of OSA in the management of chronic cough, obstructive sleep apnea?
So again, this is a very, very good question. Actually, OSA is considered as a new word cough disease. So in fact, it is again one of the disease which predisposes to cough, and cough predisposes these patients to develop more and more inflammation of the upper airways and development of increase in AHI or worsening of the obstructive sleep apnea syndrome. So in fact, 8% of patients of obstructive sleep apnea do have chronic cough. And there has been always a debate whether OSA leads to cough or cough worsens their OSA. But it seems again it is a vicious circle where it is going all around. And again, the GERD is importantly playing a role there also. And CPAP has been shown to improve the cough in these patients. And this is again one of those occult causes of chronic cough where the multidisciplinary team will sit down and decide that it looks like OSA and let's do the sleep study and give a CPAP trial and see whether this cough improves or not. But invariably, as I said, it is associated also with a gastroesophageal reflux or a nasal or a sinus disease, which needs to be treated simultaneously.
Perfect. So next question is, the response of empiric therapy in chronic cough management, can it be useful in making the diagnosis of possible etiology of the cough?
So this is exactly what I said in the presentation, that the cough resolving with the empiric treatment is an indirect diagnostic criteria to use, that is the diagnosis. Be it asthma, be it rhinosinusitis, be it GERD. So all these three diseases are primarily treated on empiric grounds. And if the patient becomes better with one of them, then that is a definite diagnosis for GERD as well as the rhinosinusitis causing cough. For the asthma, still you would like to confirm the diagnosis because of the various reasons and the long-term treatment required. But these conditions are basically lifestyle conditions which will require a lot of modification in their daily lifestyle, which anyways are going to be good for the patient. You may not go for invasive procedures to diagnose these conditions.
Right. So, sir, on this note, I would like to announce that we do not have any further questions from the audience. And I would also like to thank audience for asking such an interesting questions. And on this note, may I request Mr. Ravinder to kindly proceed with the vote of thanks.
Yeah, thank you, Dr. Varsha. So, first of all, my sincere thanks to
Mr. Ravinder, I think there is a technical glitch at your end.
Yeah, Varsha, you conclude the session then without.
Sure, sure. So Dr. Talwar sir, thank you very much once again on behalf of Lupin Limited for giving us such an insightful and interesting talk and taking out your time on the Saturday evening. We really appreciate it. Thank you very much. And on this note, we can conclude the session.
Thank you, everyone. And thank you for
Thanks a
joining.
lot, sir. Thank you very
Thank
much,
you, sir. Thank you, ma'am.